Welcome back to you and our audience. I am thrilled and honored to have with us now Dr. R. Lawrence Moss, the President and Chief Executive Officer of Nemours Children's Health. We are so excited to have Dr. Moss here. He's going to talk about a new definition of health. And at the end, I'll be asking him some questions about the presentation. Please take it away, Dr. Moss.
Thank you, Mark, and thanks to you and Healthcare Innovation for the generous invitation to speak at this forum. As of all of us, I was very much hoping we'd be together in person in Miami for this event, and I'll just say that I look forward to doing so in the future. But this is a great opportunity as an alternative to interchange some ideas and have a conversation. So thank you for asking me. Thank you for putting the health of children front and center in this meeting. Very important to me personally, and I hope you will agree with me after my talk that it's very important to the future of our country. Oops. There we go. Before I jump into what I want to say today, I want to tell you a little bit about my organization, Nemours Children's Health. We are a leading multi-state, multi-hospital children's health system. In fact, we're the only children's health system in the country that's geographically dispersed in the way we are. We have a lot of operations in the Northeast, in Delaware and Metro Philadelphia and Southern New Jersey and Maryland. And we're also throughout Florida and the Southeast. And we take care of kids from the reddest states to the bluest states, from the most advantaged counties in the country to the most disadvantaged counties in the country. And we believe we have an important role and an important obligation to transform the way America takes care of kids. And I'll take the opportunity of this talk to say a little bit more about that as it unfolds. We're a large organization that is the enduring legacy of the famous American industrialist Alfred I. DuPont. It was actually an intent of his will in the early 1930s that created our organization. We currently see almost 2 million patients a year. We have close to 1,000 physicians that work for us and 8,500 employees or associates that are part of our organization. We're an academic health system, so research and education is an enormously important part of what we do. At any given point in time, we're training 3,800 doctors, nurses, allied health professionals, and a whole host of people who will enter the healthcare workforce. And our annual revenue is roughly $1.9 billion. With that said, this talk really has one premise, and I want you to think hard about this, and that is that investing in children's health is the single most powerful means to ensure a healthy generation of Americans and a robust economy. The action I'm going to talk about, and I'd like you to consider, is that we must transform our definition of child health and the way we pay for it in order to leverage this power. So I'd like to tell you about a little boy I took care of earlier in my career. Before I joined Nemours in my current role, I was an academic pediatric surgeon and spent my career operating on kids with severe congenital anomalies and advanced cancer. So I took care of the 1% of the 1% of kids in this country who need high-end tertiary quaternary care. That's what Nemours is primarily known for. We will always do that at the highest level, and we will always provide that service. But what I believe distinguishes Nemours from some of our peer organizations is we are equally committed to the other 99% of kids who are trying to stay healthy. And our health system in America does not do well by that other 99%. We'll see some data to explain that, and we'll talk about how we could change that in the future. This is a little boy named Wendell. And Wendell was literally one of the very first patients I took care of after I finished my training. My first faculty job was at the University of New Mexico, and it was literally my third day on the job when I was called urgently to the emergency department to see an 8-year-old boy with a red leg. Not the most exciting thing you'd think out of the blocks for a new surgeon, but when I got down there, it was readily apparent to me that Wendell had what is called necrotizing fasciitis, and that's what is commonly referred to in the lay press as flesh-eating bacteria. He had a very, very aggressive bacterial infection of his leg, which was rapidly spreading throughout his body. Before I was finished with Wendell, I had operated on him 17 times. I had removed all the skin and subcutaneous tissue and muscle fascia, over 90% of his body surface area, and ultimately had to do some pretty creative skin grafting to rebuild that or recover that 90%. I also had to amputate his right leg. It was a horrendous challenge for Wendell and his family, and I'm very fortunate to say that he did survive, and he has grown up, but he survived with pretty significant disability. When I reflect back on my experience with Wendell and the experience of Wendell's life, it really is a wonderful illustration of what we call upstream issues in healthcare. And the best way I can articulate to you what I mean by that is by going through a series of questions. So Wendell developed severe necrotizing fasciitis that almost killed him and took 90% of the skin and his right leg. Why did he get this infection? Because he got a deep cut in his leg playing in the trash. Why was he playing in the trash? Because his neighborhood is run down and has no parks or places to play. Why does he live in that neighborhood? Because his parents cannot afford to live in a nicer neighborhood. Why can't his parents afford to live in a nicer neighborhood? Because his mom is obese with diabetes and his dad is unemployed and caring for her. Why can't his dad find a good job with flexible hours? Because he grew up without education and without a good education and has no skills. Why aren't Wendell and other kids supervised after school? Because after school programs in Wendell's neighborhood were cut to address a state budget deficit. And the story goes on. Well, the tip of the spear, or the end point of Wendell's many social problems, played out in a severe medical problem. Wendell really didn't have a medical problem that caused this severe issue. What about the economic cost of a situation like this? This was back in 1994, and the cost of his ICU stay was $1.4 million, probably closer to 10 million today. Estimated cost of his lifetime medical expenses, 12.3 million. The economic cost of the lost productivity of Wendell over a lifetime is something you can't even begin to put a number on. An individual who would have been a vibrant, intelligent member of society is now in a different place. What would be the cost of an after-school program in Wendell's neighborhood for 175 kids that went to his school? About $89,000. That's a pretty staggering juxtaposition. So let's step back and look at this as it plays out over the entire US healthcare system. Healthcare in America is roughly 18% of our gross domestic product. It's about a $3.5 trillion spend annually. However, almost every single penny of that $3.5 trillion goes towards paying for the opposite of what we want. We want health, but we don't pay for health in America. We pay for volume and complexity of medical procedures developed. Systems like Nemours and every other health delivery system in this country gets paid more when we deliver higher volume, complex procedures. Our economic engine is days in the ICU, complex operations, and procedures. And frankly, when patients have complications and spend more time in the hospital, we actually economically benefit. We don't want it to happen, but we economically benefit. In America, because we pay for volume and complexity of procedures, we're getting exactly what we pay for. I'm going to talk a little bit slowly while this slide is up because I want you to absorb it. These are the rates of high reimbursement, complex things that the healthcare system does in the United States compared to the average of Organization of Economic Cooperation and Development countries, which are the developed nations of the world. The United States does more than double the number of MRI and CT scans. We do way more tonsillectomies. We do way more coronary bypass operations, knee replacements, and cesarean sections. All of this happens with no difference in the disease burden between the United States and our peer nations. In fact, by some measures, our disease burden is actually less. So why do we throw complex procedures at every problem? Because we're economically incentivized to do so. So what are we buying with all this money? Well, we're buying procedures. We're buying volume and complexity. We certainly are not buying health. This is a ranking of some health status indicators of all of the OECD countries. Life expectancy at birth, highest in Japan, lowest in Latvia, about 32 out of 38 in America. Infant mortality, 34 out of 38. Management of chronic diseases like asthma and diabetes, near the bottom. Safety during childbirth, near the bottom. The only place where we reach up to about the median is heart attack mortality. Well, it's not an accident that a lot of heart attack mortality prevention involves procedures. So it's a fortunate overlap there that the country that pays for procedures has decent, not great, but decent metrics in that area. This is a graph with total expenditure on healthcare per capita on the x-axis and life expectancy on the y-axis. And you can tell roughly the more a country spends on healthcare, the better life expectancy is, with diminishing returns. The low end of the curve at down by 1,000 is steeper, and then that levels off as we spend more and more. That holds true for every nation in the world except for one. And you can see the green circle on the right of the slide, which is us, the United States, which is not just an expensive healthcare system, it's a massive, massive outlier. You can see that we are in a category by ourselves in terms of spending, and in terms of life expectancy, way, way lower than we ought to be for how much money that we're spending. We think of maternal deaths as something that happens in the developing world. And largely the countries named on this slide in white are where the problem with maternal death is, except you can add one country to this list, and that's the United States. And if you want to go to the bottom of this list, look at Black infants in the United States. So this isn't really a talk about health equity, which is entirely separate. Well, it's an entirely different type of problem, but it really isn't different and it really isn't separate, because health inequity in the United States is so massive that we as a nation have no chance of achieving good health without addressing health equity. I've made the statement before that there can be no health without health equity, and there's no country in the world where that's truer than in the United States. This slide looks at Black maternal and infant mortality rates, and I don't have to go through the numbers with you in detail to have you see the massive difference in mortality rates. This is true of birth-related mortality, overall infant mortality, and it's also true of unexpected sudden infant death syndrome. And you can see that the disparity also exists in morbidity, whether you're talking about low birth weight and small for gestational age, congenital malformations, or maternal complication rates, big, big racial disparity. So what have we actually bought with our $3.5 trillion? This is an index of child well-being or overall well-being. You can see There are multiple dimensions: maternal well-being, health and safety, education, behaviors and risks, housing and environment. We're near the bottom in almost all of them. And when you look at our average rank, when you combine all 5 dimensions, nothing against Lithuania and Latvia, but that's not the company we should be keeping with the resources available to our population in this country. So at the root of our challenges in this nation is the way that we define health. In the United States, we tend to equate health with medical care, when in reality, nothing could be further from the truth. If we look at all the things or the factors that impact a child's health through development, medical care accounts for roughly 15% of health. All of these other things that you can see on the slide account for 85%. Yet, how do we spend our money? Well, on the left side of the slide here is the determinants of health. The vast majority of health, 85%, health, behavior, and other factors, a small amount, medical care. How do we spend our money? We spend 97% of our resources on medical care. So we spend 97% on 15% of the issue. We spend 3% on 85% of the issue. And if you think about the spending, we are indeed getting exactly what we're paying for. So what I'm talking about, the other 85%, is often referred to by the euphemism social determinants of health. Well, it's an overused term, and sometimes it means different things. It does squarely point at the issue. The social determinants of health, as defined by the World Health Organization, includes the conditions in which people are born, grow, live, work, and age. And largely, they are shaped by the distribution of money, power, and resources in the world. And disparities in the social determinants of health are directly related and responsible for most of the health disparities we see. Around the wheel here, you can see 5 particular leading social determinants of health. They're important enough that I'd like to take you through a little bit of a story of each one individually. So let's start with education. Now, here's a graph of the impact of some healthy behaviors on the length of our lives, quality adjusted life years. So if you get your pap smear every year in comparison to people who don't, it adds about a month to your life expectancy. If you get your mammogram every year, adds about 2.5 months. If you normalize your LDL cholesterol versus people who have LDL over 160, it adds about 3/4 of a year to your life. Normalize your blood pressure, buys you about 1 3/4 years. Smoking, we know smoking's a big deal. People who never smoked versus people who smoked 30 years are going to live about 6 years longer. But the difference between a high school diploma and an advanced degree, 12 years of life expectancy without adjusting for any other medical factors. So it just puts in perspective the order of magnitude of impact of some of the social determinants of health. What about nutrition and food security? You could look at this through a lot of different lenses. This particular study I'm showing you here is an anecdote. If we look at food insecure, the green bars, versus food secure children in a variety of risk factors, and you can see that all of the food secure have been normalized to 1, almost double the chance of the child being in fair or poor health, more than double the chance of behavioral problems, close to double the chance of developmental delays, nearly triple stomach aches, headaches, and more cold. So by almost any lens, being food insecure portends worse health outcomes. What about housing and living conditions? Again, an anecdote, and one of many different anecdotes I could tell. I could tell you about. This looks at housing status as an independent variable. So this is a multiple regression analysis correcting for the other variables in kids who are homeless versus low-income kids. Remembering, low-income kids have pretty poor health indices to start with, so it's not a high baseline here. When you compare these two groups, the homeless kids were twice as likely to end up in the emergency department, twice as likely to be hospitalized for acute disease within 1 year, twice as likely to be in fair or poor health, and way more likely to have acute illness problems. And I put the last bullet here as a reminder that this is not about insurance coverage. Both of these groups had coverage by Medicaid. So this goes deeper than an insurance coverage issue. Let's take a look at income and social status. One of the places that Nemours operates and takes care of many kids is in Metro Philadelphia. These are, the neighborhood names might not be familiar to you unless you're from Philly, but these are two neighborhoods in Philadelphia that are 5 miles apart. You can travel 5 miles on the subway in Philadelphia, and at your beginning point, a baby born today is expected to live to age 88. Go 5 miles down the road, and a baby born in that other neighborhood is expected to live to age 68. 6 years less than the life expectancy for a baby born today in Iraq or Syria. This is right here in our own backyard, right here in the wealthiest country on the planet, and clearly within our capacity to make a change. Finally, let's take a look at adverse childhood experiences. Probably something you've heard about either through the mainstream media or through other sources, but I believe it deserves a bit of a drill down for our purposes today. So as you recall, adverse childhood experiences include emotional or physical neglect, physical, emotional, or sexual abuse, growing up with family members with mental illness, alcoholism, or drug, family violence, incarcerated family members, growing up with one or no parents. So they're essentially a catalog of bad things that can happen to kids during their developmental years. The largest study that looked at the impact of adverse childhood experiences was a collaboration between the United States Center for Disease Control and the Kaiser Permanente Foundation. This was a 10-year study involving 17,000 people, and it looked at the impact of these adverse childhood experiences over a lifetime. 2/3 of kids in the country, because the study was essentially a cross-section of kids in the US, 2/3 had at least one, 25% had at least two, and 12.6% had 4 or more. 22% of kids sexually abused as children, and 66% of the women experienced abuse, violence, or family strife. So what about the outcome of this? Let's first look at the health outcomes. In comparison to people without ACEs or adverse childhood experiences, those with 4 or more, as adults, were twice as likely to smoke, 7 times as likely to be alcoholics, 6 times as likely to have had sex before age 15, twice as likely to have cancer or heart disease, and 12 times more likely to have attempted suicide. But the impact of ACEs goes way beyond health indices. What about the economic indices? Oops, I'm sorry, I might have skipped the slide here. Yes. Oops, there we go. I'm missing a slide, but I'll tell you the information, and that's that people with ACEs in this category have a lower high school graduation rate, they have a lower median annual income, they're more likely to be incarcerated, and they essentially live in a markedly lower socioeconomic strata. So, next topic. Can we do anything about this? So does investing in the social determinants of health or trying to make a difference in early childhood actually matter? And the reality and the evidence is overwhelmingly yes. And 3 of the studies that articulate this or demonstrate this most clearly are on the slide. I'm going to spend a moment on the Abecedarian preschool program. So actually, let me take a moment and tell you a little bit about this before I go to that slide. The Abecedarian Preschool Project was a social experiment in which about 287 kids were randomized to 2 different types of preschool. The control group had normal, acceptable preschool in their community. So they did go to preschool and they had the same thing that the general population got. The study group got a relatively minor, or at least minor in terms of cost, intervention. This included 2 meals a day and a healthy snack, periodic medical checkups, access to pediatric primary care, and some instruction in healthy behaviors and lifestyle. Remember, these were all kids under 5, so this was not a graduate level course in healthy behaviors. This is pretty basic stuff. The kids who participated in this study were actually followed prospectively for over 30 years. So we followed these kids into it, not we, but the investigators in the Abecedarian Preschool Project followed these kids into adulthood. 30 years later, the kids who had these simple interventions in comparison to the control group had a lower systolic blood pressure versus controls, and not a little bit lower, 20 points lower. They were less likely to be stage 1 hypertensive in their 30s. 0% of them exhibited deadly metabolic syndrome versus 25% of the control group. And we all know that metabolic syndrome strongly portends an early mortality. They had higher levels of HDL, which is the good cholesterol, and they had a lower incidence of severe obesity, a lot lower, less than a third lower. What about their economic outcomes? Increased high school graduation rate, less likely to be convicted of a crime or incarcerated, higher median annual income. If you were able to annualize the economic outcomes based on the money invested in the project, there was a 13% return per annum. Imagine that compounding over 30 years, and that's absolutely massive. And one of the unexpected and really wonderfully surprising benefits was that there was a 2-generation of. So the study was long enough that these kids were followed into adulthood, and many of them had kids of their own. And it turns out that the healthy behaviors that were instilled in these kids during their Abecedarian preschool experience, when they were birthed to 5, they were passing on to their own children at absolutely no cost to society. So what does this look like for the future? Well, this is Nemours' vision for the future. Today, as a nation, we spend a massive amount on medical care and healthcare, and 93% of this spend is on adults. We suggest spending a little bit more on kids, but mostly spending differently on kids. And 10 to 20 years later, the overall magnitude of this spend goes down a ton, because while we think of diabetes, cancer, heart disease largely as adult problems, they're not. Those seeds are sown in childhood. And once those seeds are sown, it's extraordinarily hard and often impossible to reduce that trajectory. If we can change that trajectory in childhood, we're looking at a markedly different generation of adults 10 or 20 years from now. So what does Nemours do about this, or what does Nemours intend to do about this? It begins with a commitment to provide services and care for every child in need, regardless of ability to pay. And that is a core operating principle of our organization. We will provide the medical care needed to every child, regardless of ability to pay. it continues with a particular focus on underserved areas and underserved kids. I made the statement earlier, there is no health without health equity. When we can make a difference in the most disadvantaged kids, we move the overall needle in population health the largest. It continues with an investment in capabilities, knowledge and capabilities to care for populations. And this is different than caring for individual patients. I'm going to say a little bit more about this as I continue to describe what we're doing. To date, Nemours' investment in this population health approach is about $75 million. In today's economy or today's healthcare system, that's $75 million to which there is no return. Not only is there no return, we actually lose money when we keep populations healthier. As I told you, in the current economic climate in healthcare, there's actually a disincentive or a penalty for preventing illness and keeping kids out of the hospital because we get paid for hospitalization and delivery of high volume, high complexity care. We intend to change that. And we believe once healthcare is transformed, Nemours will be remarkably well positioned to take care of kids in the best possible way and to thrive economically. We're just a number of years ahead of the curve. We have developed at Nemours through this $75+ million investment, the value-based service organization, or what we affectionately refer to as the VBSO. The four components of our VBSO or the four arms are a medical management arm, which is more about care management of the individual patients and subsets of patients. Population health management, which is an entirely new concept in healthcare, where we're looking at the population, not so much at the individual patients. We have a very sophisticated data analytics and technology group. And finally, in the state of Delaware, we've developed a statewide clinically integrated network, which gives us the power of numbers to implement the first three arms. Just a few introductory comments. Care management includes things, for example, so these are anecdotes, developing NCQA accreditation for the management of multiple chronic diseases and children with medical complexity, who are a big, important population if you're going to be able to manage the overall population. We offer care management to all the practices in our CIN, whether they fall under Nemours' economic umbrella or not. And we have extensive care coordination through our primary care practices. Population health management, we've implemented a, social determinants of health screening tool. We've improved the connection of our families to resources. So we don't have a fully articulated, fully operational, complete closed loop system with our social determinants of health screener, but we're moving in that direction, and that's our aspiration. And we've done some really good work around trauma-informed care. Our data analytics platform supports population health using Epic's Healthy Planet. We have clinical registries, race and ethnicity registries, economic registries, neighborhood registries, and we're able to cross-pollinate all these data to ask and answer some really interesting questions that could not be asked and answered by the typical healthcare system. And I'll tell you a little bit more about our predictive analytics and our digital strategy as I go forward. One example of what we learned and what all of pediatrics has learned, that 5% of our patients account for 60% of our spend. The top 1/10 of 1% or 0.1% of our patients account for 12% of our total spend. And as we began the VBSO, we were operating under expectations for 99% of the patients. But for that expensive 1%, we were not doing so well. And this was what was throwing costs out of bounds. This just demonstrates this graphically. If every one of these boxes is a child, you can see that, and the size of the box is the medical spend or the cost of medical care for a year, you can see that a few kids account for a lot of spend, and a lot of kids here don't cost very much. So this is the high cost, high complexity patients. You can even look at, let's see, 1, 2, 3, 4, 5 patients out of well over 100,000 account for almost 10% of the spend. That clearly requires focused attention on this subgroup. And that's exactly what we've learned to do through our VBSO, is help children like this who have high medical needs and require a level of medical management and a level of care management that other kids don't. So just opening up a care management platform and rolling it out to everybody is not the answer. It's rolling it out in a targeted, deliberate, and thoughtful approach. And we've been able to not only improve the health of this population of medically complex kids, not only keep them out of the emergency department and out of the inpatient wards, but markedly lower their cost of care. Care coordination, this just tells a little bit about our activity. In 2018, we had about 6,000 outreach efforts between our care coordinators and families. 2 years later, it was up to 67,000 encounters. So really taking hold and really making a difference. Examples of registries that we're able to cross. We've got chronic disease registries, surgical registries, registries of kids with medical complexities. We can cross this with geography, neighborhoods, zip codes, median income, technology available, whether or not these families have internet access, who their payer is, et cetera, et cetera. So we can ask some very interesting and creative questions. And then you combine this with data from the social determinants questions, and you can ask, who are all the patients with chronic medical complexity who are at risk for food insecurity, and how many of them ended up in the hospital in a 12-month period compared to kids with the same medical status who didn't have food insecurity? Just one example. We can ask and answer those kind of questions with the click of a button and have an entirely more robust lens on our population of patients. This is just a little bit of an example of that and the way that we do that. I'm not going to spend too much time on the slide. I'll just go on to say that we are also able to disaggregate the data by race and ethnicity. So every creative question that we can ask, add to that, how does the answer to that question compare in our African American patients versus our white patients? How about our Native American patients versus the other ethnic groups? It's an entirely new and entirely newly powerful window into a patient population that allows us as a health system to behave and respond in ways that we couldn't have even conceived of 5 or 10 years ago. What about successes? The Delaware Children's Health Network, which is our CIN. So this is not just Nemours, but also all these practices that we do not own and operate that have joined us as part of our clinically integrated network. For 2021, we met or exceeded benchmark in 8 of 9 Medicaid quality measures. We met or exceeded benchmark in 10 of 10 on our commercial contracts. We had a maximum score in a pretty high percentage of those health metric measures. So not exactly where we want to be. We should be 10 out of 10 in everything, but pretty encouraging early results. So where does this all go? This is an overall perspective of healthcare in America. If you're the 1% of the 1% who needs tertiary quaternary care, so if you're the kind of kids that I used to take care of as a pediatric surgeon, the United States is absolutely the best place in the world to get your medical care, your child's medical care, hands down. However, if you're the other 99+% whose agenda is about keeping from getting critically ill in the first place and about growing up healthy with the lowest incidence of heart disease, the lowest incidence of cancer, the lowest incidence of diabetes, this is not the right place. What I'm talking about today is making it the right place. And that is Nemours' national leadership agenda. We believe that it is possible to reinvent and reimagine the definition of child health in this country and to markedly change or flip 180 degrees the way that we pay for it. So put on your imagination hat for a minute and try to envision a nation where the rate of chronic disease declines by more than half. Based on what I showed you from the Abecedarian Preschool Project, it's pretty inexpensive and theoretically pretty easy for us to get there. Imagine if the average American family spent 50% less on healthcare while also enjoying a better quality of life. Imagine if the rate of adverse childhood experiences was reduced by 2/3. Imagine if increases in high school graduation, literacy, and numeracy put our children, American children, on par with other developed nations. And then put it all together and imagine, what if we spent 10% of our gross domestic product on healthcare instead of the 18% we currently spend, saving $1.72 trillion annually. And imagine if we could invest that in a thriving economy with a truly healthy workforce. That is a pretty exciting future, and that is a fully attainable future. So thank you so much for listening to me today and the opportunity to speak with you. Thank you for joining this meeting and for the exciting things that we're going to learn through the rest of this meeting. It's been my privilege and my pleasure to speak with you. And I'm going to turn it back over to my colleague, Mark, and I think we'll talk for a couple of more minutes.
Dr. Moss, thank you so very much. I can guarantee you that if we were all gathered together in person, that you would be receiving a standing ovation right now. And I would stand, except then you'd see my belly instead of my face. But that was an absolutely wonderful presentation, Dr. Moss. I really sincerely applaud you. And I sincerely applaud the fact that you are bringing this vision to many audiences, and I hope that they're listening. So that's the first thing I wanted to say. I would like to just engage for a few minutes. One of the things that really, first of all, I absolutely love that you began with the human story, the story of Wendell, your patient. I think that that helps people to, even in healthcare, helps people to kind of get a grip on this, right? We can be overwhelmed by statistics, right? You know, and you certainly had many, and they were all super useful. But when we zero in on what this means on a human level, we can understand, right? And we can understand that there are many Wendells, and that our job as a healthcare system is to do something to help the whole Wendell. So my first question to you is, many organizations are on some version of the path that you're on, which is expanding their vision towards whole health of communities. How do you decide what belongs to the health system, meaning a specific organization like the Moores, and the US healthcare system overall, and what belongs to other stakeholders? I think one of the challenges in health equity work, in SDOH related work, even in population health management related work, is that when you get to some of these social issues, including food insecurity, personal safety, housing insecurity, transportation, you know, all quality of life issues, it can get a little bit fuzzy at the edges, right? Between what the health system is supposed to do, the healthcare system, and what community organizations, local and state governments, the federal government are supposed to do. How are you helping your colleagues to navigate that kind of borderline, Dr. Moss?
Thanks, Mark. Really good question. You always cut right to the heart of the issue. I'll before I get specific to your question, I'll make a response about your comments about stories. Stories to me are very, very powerful. I think about a famous quote from Joseph Stalin when he was asked about how he executed so many of the atrocities that he did, and he said that one death is a tragedy, 1 million deaths is a statistic. And that really drives the point home to you, that to me, that the stories lie, I'm sorry, the power and the emotion lies in the stories. And that's very personal to me, because everything I do in healthcare now and everything that's driven me to my current role at Nemours and point in my career comes out of the one-on-one experiences I had with patients like Wendell and so many others I can remember. And they really made the situation real to me and helped me develop my passion behind these issues. So you asked important questions about the role of a health system, and I would answer that in a couple ways. So what is our role? You know, we're experts in delivering medical care. What are we doing getting our fingers into housing and education and all of these other things? And I would suggest to you, the operative word is steward. So Nemours has no intention of taking over those areas or being the expert in those areas, because we're not. But what Nemours can do and what children's hospitals can do in this country is become more than places families go for delivery of medical care when their kids get sick. We need to become the stewards of children's health in American society. Or another word that goes along with steward is convener. I believe it is our opportunity and our obligation to get the right folks to the table, whether it's about education, whether it's about housing and food security for kids, or whether it's about a myriad of other social determinants. We're the voice of children in this country, and I believe the obligation is on us not to shy away from 85% of things that contribute to the health of children. I mean, you can't care about the health of children and only invest your time and energy and institutional resources in 15%. You got to care about it all. And the next point I'd make is that I don't believe there is any linear trajectory from our current health economics to a fully capitated system where we actually get paid for health. And pay for health is an important buzzword for me, because that's where we want to get. It's got to be a quantum leap, and there's going to be risk and uncertainty on any healthcare system who makes that quantum leap, and Nemours is prepared to do that.
And I think that's perfect, Dr. Moss. I love the terms convener and steward. I think that those terms frame it very well. Let me ask just one or two more questions. Okay, so inevitably, I'm going to talk about Medicaid, just because I'm a journalist. You and I have spoken numerous times now about this, but it seems clear that we need to reform the Medicaid program along several dimensions. One is reimbursement. As a children's health system, you derive at least the plurality of your revenues from the Medicaid program. Medicaid has been underpaying in states for many, many years now. How do you, and I know you said very clearly to me, and I remember everything you say. How do you navigate some of these issues without inadvertently ending up framing yourself and your organization and all children's hospitals, all children's healthcare organizations as, complainers, quote unquote, whiners, when in fact, everything that you shared in this presentation is so crystal clear to me. I don't think anyone could argue with it. However, state legislatures are hard things, and convincing them to invest more in children's health through responsibly reimbursing providers remains a very, very heavy lift, a very hard thing to do. And as you know, of course, the states are all over the place. Some states are paying, basically about half of what others are for the same procedures and same treatments. So, sorry, this was a super long preface, but how do you address Medicaid payment reform without it seeming like just a money, a money discussion, right? How do you bring the wonderful elements that you just presented here into that discussion so that state legislators get it?
Yeah, really good question. And obviously not possible to have a cogent conversation about children's healthcare without talking about Medicaid. Medicaid is the source of funding for about half the kids in the United States. For the kids that we take care of at Nemours, upwards of 70% of the patients we care for. Every Medicaid patient we care for, we do so at a loss. Medicaid funds between 20 cents on the dollar to 80 cents on the dollar, depending on the state and the particulars of the child situation. So it is a challenge. And, I'm certainly not going to deviate from anybody in children's healthcare that says, hey, Medicaid reform would be wonderful. And if we could actually get the country to pay for children's healthcare at anywhere near the rate we pay for healthcare in the elderly with Medicare, it would be a huge boon for kids in the United States. That being said, that's fairly unlikely to happen. And as much as I'll continue to fight for that, and my colleagues will continue to fight for that, we need to address these critical issues, whether or not we can make that happen. So there's a lot of good news. There's a lot of bad news when you talk about Medicaid. There's also some good news. And the good news is in children's healthcare, there's a single payer for more than half the patients, and that's Medicaid. So that means we can enact major policy changes that will happen for half the kids in the country with the stroke of a pen. And we've seen the commercial industry largely follow Medicaid. So we have a good avenue for major policy change. So for example, were we to decide that it was critically important to be able to spend medical care designated dollars on social determinants, Medicaid can do that in the stroke of a pen with an 1115 waiver. So that's the good news with Medicaid, is a lot of stuff can happen at the federal level and also at the state level. So that being said, children's healthcare economics is very complicated. Improvements in Medicaid would be a big deal. And it is unfortunate for children that somehow Medicaid for kids has gotten wrapped into the false narrative that, oh, Medicaid, that's for poor, lazy people who don't want to work.
Yeah.
And I emphasize false narrative, but it's nevertheless a narrative that lives in this country and that kids have been inextricably drawn into. Again, another area we're working to change. I would suggest that Medicaid reform for kids would be a home run, but even if it doesn't happen, there's other avenues to achieve everything I talked about today.
Yeah, I appreciate that, Dr. Moss. I mean, I'm 1,000,000,000% on your side. I hope that you understand that. I just think it remains, per what you just said, a heavy lift, because there's a false narrative, a false discourse, if I can call that, around Medicaid in this country. And you're absolutely right, it persists. It somehow, not only is it seen, like poor, lazy people, that terrible, terrible narrative, but it's also like, oh, well, we're wasting money. I think if there's a single thing that you've conveyed through this wonderful presentation just now, it's rethinking, right? That we're investing in children. if children can be healthy, if children don't have to go through terrible things the way Wendell did, if Wendell had been in a wonderful after-school program where he had access to a really nice playground, he wouldn't have been playing in the trash and got that horrible cut that led to amputation. And also tremendous expense for the healthcare system, right? So I think I'd like to have us just end on a hopeful note, because I know that you're a hopeful person. I am a hopeful person too, Dr. Moss. What is your vision for, let's just say 5 years on out? I won't say 10, because I don't even know if we can imagine 10 years at this point. We're just trying to get through the next few months, but in this healthcare system. But looking about 5 years out, what would you like, if we could say, that this was December 6th, 2026, if we could, time travel really fast into that date, what would you like to have seen happened by December 6th, 2026?
Thanks, Mark. I hope we'll be well on the trajectory towards the kind of society I'm talking about. I like to talk about the lever of impact of children. And if you start with one, if you look at Wendell, his $20 million plus cost could have been prevented with a couple $100. And you magnify that from one kid to 40 million kids, it's a relatively small project to invest in kids, which are 7% of the total healthcare spend in this country, and transform society. By the time people are adults, we can and we should continue to invest in their health. It's a big investment for a little bit of return. In kids, especially from birth to age 5, it's a tiny pittance investment for just an absolutely massive return. We do a little bit of that, and we're going to look pretty good even 5 years from now, and wonderful 20 years from now. So thank you, Mark, for the opportunity. Always enjoy being with you, and I look forward to the rest of the conference.
Thank you so much, Dr. Moss. And I'll just make one specific comment, which is, I think we have to think of children's health in the early years as the healthcare equivalent of Head Start, right? Now there's the pushes on to give every child preschool education, which is kind of a no-brainer in my mind. What if we could give every child a good start at lifetime health? Wouldn't that be amazing? So, Dr. Moss, thank you again. I want to thank you for your extraordinary leadership, both as the CEO of Nemours Health, Children's Health, and as an individual, because you are shining lights where they need to be shown, and you're helping people to understand what we need to think about and what we need to do. So thank you for this time together. And may the wind be beneath your wings, and truly may the road rise up to meet you. Thank you so much, Dr. Moss.
Thank you for the very kind words, Mark. And on behalf of all of Nemours, we appreciate the opportunity to talk to you and look forward to comments from our rest of our colleagues at the rest of the meeting. Thank you.
Absolutely. Thank you. Thank you, Dr. Moss. And thank you to you in our audience for participating in this session. This concludes this session. Thank you very much.